Hello, everyone, and welcome to the Les Turner ALS Foundation's March ALS Learning Series on cognitive changes in ALS with Dr. Catherine Lomen-Hoerth. Before we get started, I just want to remind you all that you are all on mute and off camera, so just sit back, relax, and enjoy the presentation, which should take about an hour. If at any point you need to drop off or something comes up, we are recording it, and this will be live on our website and YouTube channels within the next day or two. So if you have to leave, don't worry, visit our website. That'll be a great place to pick up where you left off. I'm Anne-Marie Doyle. I'm the Community Education Manager at the Les Turner ALS Foundation. And before we jump into things, I just want to tell you a little bit more about the foundation. So the ALS Learning Series is made possible because of the Gilbert and Jacqueline Fern Foundation and our industry partners, Mitsubishi Tanabe Pharma America. So who are we? At the Les Turner ALS Foundation, we are leaders in comprehensive and personalized care. It's that people are overwhelmed and unsure of what questions to ask or what to do next. And that's really where our support service team shines. Our support service team is comprised of knowledgeable and compassionate nurses, guiding people and their families affected by ALS. We offer a variety of services, including but not limited to care visits, meeting people to community. At the Turner Western Medicine Clinic at the center at Northwestern, ALS access to enroll trials, disciplinary team, support throughout your journey. Again, making about your ALS care can be overwhelming, but your help is overwhelming helps. Visit us at lesturners.org. We have research about your care options or want to visit past ALS learning. All right, and so now I am pleased to introduce you to Dr. Catherine Lomen-Hoerth, a neurologist and director of the ALS Center at University of California, San Francisco Medical Center. She is particularly interested in research involving electrophysiological and genetic predictors in ALS, along with the overlap of ALS and frontotemporal dementia. Dr. Lomen-Hoerth earned a bachelor's degree in biochemistry from the University of Arizona, and both her medical doctorate degree from Stanford University School of Medicine. And she's also an active member of the ALS Association's Bay Area chapter. Welcome, Dr. Lomen-Hoerth.
Thank you so much. And is the sound cutting out for me intermittently, but hopefully.
Yes, hopefully that's okay.
Great.
I was seeing that too.
Well, thank you so much for inviting me to speak, and I'm excited to meet everyone virtually and look forward to answering questions at the end of my talk. I actually changed the talk with the title to talk about care for ALS patients and ALS patients with cognitive difficulties, because as we'll get to later, we have discovered that only about 50% of patients with ALS have some sort of cognitive or behavioral difficulties. So it's important to think about the care for all patients with ALS. So just to dive right into it, what do we know about ALS today? Well, we know that it is unfortunately universally fatal. The mean survival after the first symptom is 3 to 5 years, but the progression is very variable. I have had patients who have passed away 2 months after their first symptom, and I've had other patients who are still walking 20 years later after their first symptom. So it's very variable. It is the most common adult onset motor nerve disease, and we don't understand what causes the disease, and that's what makes it very challenging to treat the disease. It's very heterogeneous. Every patient is unique as far as where the disease starts, how it spreads, how quickly it spreads, what symptoms each patient has. And so I just wanted to quickly go through a sample case in case there are people on the phone who are not as familiar with ALS, but Lou Gehrig was a typical rapidly progressive patient with ALS. He started having some difficulty with skating, dropping things, started to have some decline in his performance, playing baseball, and then he was diagnosed in June of 1939. And mostly had limb onset symptoms, but then started to develop difficulty speaking in 1940 and then passed away in 1941. And I like this quote, but even from the midst of it, he saw himself not a mere victim of a form of paralysis, but a symbol of hope for thousands of sufferers of the same disorder. So I mentioned ALS is very variable. Its diagnosis is clinical, so there's not a blood test we can do to say that this is the diagnosis. And it's a process of excluding all the other things that look like ALS. Patients can vary in terms of their cognition in behavioral involvement. As I mentioned, about half of patients have no difficulty at all, and about another half have some subtle changes, with a subset of that having more severe changes. And we really need to understand and categorize patients accurately, because ultimately that may affect treatment and the effect of treatment on the different patients. So frontotemporal dementia may be a new term for you, and I just wanted to explain what that is. It's a disease where there's selective degeneration and atrophy in the frontal and then the anterior temporal lobes of the brain. Patients have personality changes, they may have language difficulty or behavioral disturbance. It's progressive and irreversible, just like ALS. It's not a higher risk in patients who have pseudobulbar affect or easy laughing and crying. There are very clear criteria established for this disease, and it's very different from Alzheimer's disease. Memory is preserved. In Alzheimer's disease, memory is one of the very first symptoms of the disease. There are three major variants. There's a frontal variant where patients have a lot of apathy. They may be disinhibited, decreased speech output, and not from difficulty speaking, but not the motor part, but the brain is actually causing decreased speech output. They may be disorganized and have poor insight. And then there's a semantic variant where patients have loss of semantic knowledge, meaning difficulty comprehending words. They may have word finding problems, but good insight. And then the non-fluent variant is where patients have non-fluent, effortful speech. They may have some grammar issues, but good comprehension. And once again, all of these speech issues are not because the person's tongue is weak. Obviously, if your tongue is weak, it's very difficult to speak, and at some point, there are many patients who are unable to speak at all. That is not what we're talking about. We're talking about someone where the motor functioning of the tongue is normal or near normal, and then the patients are having difficulty getting words out. A simple example would be, I might ask a patient, name as many words that start with D in a minute, and they might only be able to think of dog and done as two words that start with D in a minute. There's a genetic overlap between ALS and FTD. So about 10% of ALS patients, it runs in the family, and about 40% of FTD patients, it runs in the family, meaning that an affected member may have only ALS, only FTD, or both, which suggested a relationship in the pathogenesis of these two disorders. And later in the talk, we're going to talk about, do these conditions overlap in sporadic cases where there's not a genetic cause. And then we're going to talk about this spectrum between ALS and who are cognitively normal and patients with ALS who have dementia. I wanted to just say a quick word about environmental risk factors for both ALS and for FTD and for Parkinson's as well. So chronic traumatic encephalopathy is something you may have heard about in the news. It was associated with boxing. Initially, that's when it was first described. And there were associations with Alzheimer's, frontotemporal dementia, ALS, as well as Parkinsonism. And what they found is that the pathology was very similar in these particular cases. And then there's also an increased frequency of degenerative disease in trauma-causing professions, such as soccer players, where they use their heads to hit the ball a lot, NFL football players, and military veterans. They are all more likely to get ALS than those who are not in these professions. And for the military, it's higher in deployed veterans versus non-deployed. So we don't know the details of what some of the risks are besides trauma, but there's clearly an environmental effect on the risk for getting ALS. So what is ALS? Well, ALS is a combination of both upper motor neuron degeneration and lower motor neuron degeneration. And so in this slide, I don't know if you can see my mouse, but the dashed lines in the picture are called upper motor neurons. And then the solid lines in the picture are called lower motor neurons. Symptoms of upper motor neuron damage to the nerves are things like slow speech, a brisk gag or tapping on the jaw and getting a reflex, brisk limb reflexes, spasticity or stiffness of the muscle. Those all are symptoms of damage to the upper motor neurons, the dashed lines in the picture. Damage to the lower motor neurons causes things like atrophy, fasciculations, or twitching of the muscles, and weakness. And so, as I mentioned, patients can have exclusively ALS, or they can have ALS with damage to the frontal and the temporal lobes, where they may have some cognitive or behavioral changes. There are steps in the management that are clearly outlined in the AAN practice guidelines, which should soon be updated. They were last published in 2009. But I think the basic steps really have not changed. And that is, the first step is making an accurate diagnosis, breaking the news very carefully, providing hope, providing treatment, providing options for the patients, as well as letting them know that you'll be there with them through the entire process, starting treatments to slow down the rate people are progressing, managing breathing issues, managing issues around nutrition, and then treating many of the symptoms that reduce quality of life. Symptoms like excess saliva, easy laughing and crying, stiffness, cramps, helping to maintain mobility, providing multidisciplinary care. We know that being followed in a multidisciplinary ALS clinic helps more than any treatment we have to date to help with both quality and quantity of life. And then lastly, palliative care is important, especially in the later stages of the disease. I want to just say a word about mimics. So many things can mimic ALS. So when I mentioned it's a clinical diagnosis and there's characteristics, features, there's also a lot of other diseases that can cause those same symptoms. And so we have to make sure that we've excluded a brain disorder, that we've excluded a neuropathy, that we've excluded an endocrine problem, or heavy metal toxicity, or infections such as Lyme disease or HIV. And then people can have cancers that can either directly invade nerves and mimic ALS, or the body responding to the cancer can sometimes cause it to look like symptoms to look like ALS. So how do we treat the disease? We try to treat the disease where it's broken. And so there's so many things that are broken with ALS. We know there's a problem with too much glutamate, which is a toxic compound. Riluzole works to help with that problem. There's a problem with a release of toxic factors. The Radicava that's been approved helps with that. There's a problem with the microglia providing support to the nerve, a problem with the way the nutrition is transported across the nerve terminal, mitochondrial dysfunctions affected, and the new drug Relyvrio that was just approved this year helps to work in that way. And then there's a problem with the RNA metabolism. And then lastly, in patients who have a genetic form of ALS, such as SOD1, there can be a problem with accumulation of aggregates. So new drugs are in development to really attack all of these different pathways, and we have some of our existing drugs are working to attack these pathways. So we currently have 4 approved drugs to treat ALS. One is Riluzole, which was approved in 1993, glutamate antagonist. Nuedexta is an NMDA antagonist, and it was approved for pseudobulbar affect, easy laughing and crying, but incidentally may also help speaking and swallowing. Many patients, when they take the drug, notice that their swallowing and speaking improves. And then edaravone is a free radical scavenger that was FDA approved in 2017, now available in oral form. And then Relivrio, an oral medication, targets cell death and was FDA approved in 2022. So these are just the curves showing the improvement in survival. Riluzol's in blue, the placebo is in white. So patients who were taking a sugar pill and not the active drug are in white. And what we're looking for is a separation of these curves, indicating improved survival with patients who are on riluzole. What was nice, there's an ALS functional rating scale that was found to be even more effective at monitoring change in disease. So studies didn't have to be so long trying to look for improvement in survival. We could look for improvement in this functional rating scale that I'm sure all of you do regularly in clinic. But first 3 questions around bulbar function above the next 3 questions around arm function, the next 3 around leg function, and the next 3 around breathing. So a fairly comprehensive scale that we use clinically to monitor change over time, and has also been shown to be the most accurate measure of monitoring change in clinical trials. And so edaravone, Radicava, was shown to be effective in slowing down the disease process based on the ALS functional rating scale. And as I mentioned, was recently released in oral form so that patients don't have to get the drug IV, which was more difficult to get. And this just shows the curves that are being separated. The blue is the placebo and the red is the edaravone group. And you can see as time goes on, there's a separation of the curves indicating a slowing in the decline of that ALS functional rating scale. I mentioned Relivrio that was just approved in September of last year, and that's a combination of sodium phenylbutyrate and TUDCA. Well, TUDCA is actually an ancient Chinese remedy. It's a derivative of bear bile. So bear bile was used to treat all sorts of disorders in ancient Chinese medicine, and it has been tested in a variety of disorders and was found, incidentally, to help slow ALS. This shows the placebo on the bottom in blue, and then in red, patients who were taking TUDCA, and we see a nice separation of that ALS functional rating scale. So I just wanted to mention, incidentally, for patients that have difficulty getting approval for Relivrio, you can take TUDCA by itself, and that may have just as good of a benefit. And that's available from Amazon, and you would take 1,000 milligrams twice a day. I've alluded to clinical trials, and there's so many clinical trials for both ALS, FTD, and also patients who have the overlap. And you can find the trials in your area in a variety of ways. One is with the NIH clinical trial website, another is through the Muscular Dystrophy Association clinical trial finder, or connecting with an MDA or ALS Association certified ALS center. So we've talked about how to slow down the disease. Now let's talk about how to treat the symptoms of the disease, because there's so many things that are treatable with this disease. This is just a slide of all the things that we can treat in ALS. And so starting with poor nutrition, there can be many causes for poor nutrition. One can be swallowing issues, one can be arm weakness, shortness of breath, increased energy expenditure that comes with the disease. And so solutions can be providing better breathing support, aids to help in eating, something just simple like stacking books on a table, putting your plate on top of the books, and then being able to eat without having to raise your arm in the air can be just a simple solution often. A high calorie, high protein diet, modifying food consistency. Soft, moist food is much easier to swallow than dry, crispy food. And then considering a feeding tube to help supplement your nutrition. You can still eat whatever you like, but having the feeding tube allows you to eat for pleasure as opposed to eating to maintain your weight. And it's a balance of needs. So we always encourage patients to eat until the end of their life, if they're enjoying that. And so we want to balance that with safety. So thinking about the types of food people are eating, if they're having more difficulty getting food down, or even just putting the food in the mouth and spitting it out. If you just want that taste, that's fine too. And then we think about efficiency. How can we best support weight maintenance and hydration? And a feeding tube is recommended to be put in before your breathing forced vital capacity gets below 50%, just for safety, because you do have to lie down for the procedure. And we would hate to have someone be intubated if that was not their wish during the procedure because they were having trouble breathing lying flat. So speaking of breathing, there are many causes. The primary cause is diaphragm weakness. Chest muscle weakness can contribute to that, and as well as increased energy expenditure. So basically, if you're weak in your legs and you're trying to walk across the room, that takes a lot more effort than it did before. And so the patient may have a lot of difficulty with shortness of breath because of the effort it takes to do certain tasks. Solutions, breath stacking is something that can be done with a resuscitation bag, or oftentimes the cough assist machine is used these days to try to help really deeply expand the lungs, help to expel any secretions, and help to just improve the functioning of the lung. And then non-invasive positive pressure ventilation is recommended really as early as you qualify for the equipment based on your breathing measurements or your symptoms. Diaphragm stimulation is certainly very effective in cases where people have a paralyzed diaphragm from a static process like car accident or something like that, where you can basically stimulate the diaphragm to move. With ALS, it doesn't work as well because over time the diaphragm becomes weak in a way that stimulation will not compensate for. So that's not something that's used typically for ALS, but you may hear about it. That's why I wanted to mention it. And then of course, invasive ventilation is something that around 1% of ALS patients choose to be maintained long-term on a ventilator through a tracheostomy tube. Here are all the things that breathing equipment can help. It can help with daytime fatigue. It can help with shortness of breath. It can help with cognition. I had one patient who performed very poorly on various cognitive measures, and then as soon as he was prescribed the breathing equipment, he ended up scoring normally. So that's an important mimic of cognitive problems, is if someone is not getting enough oxygen or retaining CO2. Morning headaches is another symptom that breathing equipment can fix, as well as helping to augment speech. Sometimes people are so short of breath that it's very hard for them to get a sentence out. And so breathing equipment can help in that as well. Turning to cramps, one of the most common symptoms of the disease, there's many conservative things that can help, like stretching and hot baths. There are medications like Tegretol, baclofen, mexilotine, and quinine sulfate. Quinine sulfate can still be obtained from Canada, even though it's harder to get in the US. And then tonic water actually contains low doses of quinine. So some patients find that drinking tonic water is effective. And then spasticity. It can be really a balance between being too stiff and too loose. If you relax the muscles too much, it can be hard to stand and hard to move because the muscles are, your legs or arms may be floppy. And so every patient's different as far as how these medications work and how effective they are. So it's important to recognize that and work on your own to figure out the optimal doses of some of these medications. And not everyone with ALS has a lot of spasticity, so this is not a problem for everyone. Things like baclofen, diazepam, Valium, dantrolene, memantine, and tizanidine are all medications that have been used to help with stiffness. We often put in a baclofen pump in our institution if patients are finding it difficult to tolerate some of these medications. Many of these medications can have cognitive effects as well as effects making someone feel quite sleepy. So a baclofen pump puts the baclofen directly into the spinal fluid. It's just a pump that looks like a pacemaker. It's put under your skin and has to be refilled periodically, but will deliver a steady dose of baclofen to the spinal fluid to help with spasticity. And then Botox is often helpful for vocal spasticity. Botox paralyzes the muscle and helps to relieve spasticity. And so when it's done in the right way, that can be quite effective as well. And then too much saliva, that's a huge problem with this disease. And so medications like amitriptyline or Elavil, glycopyrrolate or Robenal, atropine pills or drops, a scopolamine patch, radiation therapy, and Botox are all treatments that help to reduce saliva. Sometimes when you reduce the saliva, it can become quite thick. And so treatments like Robitussin or guaifenesin or Mucinex, papaya enzyme and pineapple are quite good at helping with thick saliva, increasing fluids. If you have a nebulizer machine, using something like hypertonic saline and mucomist can help with that symptom. And then the cough assist machine is often great at getting the saliva up into your mouth, so then you can use a suction machine to get rid of it that way. And then I had mentioned about pseudobulbar affect, or easy laughing and crying. Well, what is that? Well, it was very hard to diagnose until we had this scale. And there, as you can see from the scale, there's 4 questions around laughing and 3 questions around crying. If someone scores 13 or higher on this scale, then that indicates that they may have pseudobulbar affect and would benefit from treatment. And so since we've had this scale, which we do on all of our patients when they come to clinic, it's made it much easier to diagnose. And we have a relatively new medication, Nuedexta, dextromethorphan, and quinidine, which helps with this symptom beautifully, and also incidentally can help improve speaking and swallowing. So even if you don't have trouble with easy laughing and crying, it can be worth trying this medication just if you have difficulty speaking or swallowing, to see if you're one of those people who benefit and improve their speaking and swallowing with the medication. It is available from a compounding pharmacy if there are insurance issues around covering this medication. And this just shows the effect. I'd like to just look on the right side. This is complete remission, so complete resolution of the problem of easy laughing and crying. And in the black bar, it shows the higher dose, which is the dose that was ultimately approved, and that shows complete remission. And approximately 50% of patients have no issues whatsoever compared to the placebo. So it really works quite well. Urinary urgency, having to get up to go to the bathroom a lot during the day or at night can be problematic, particularly if someone also is having mobility issues. And so there are some medications that can help, some anticholinergic medications. Condom catheters are often used. Sometimes people will have surgery to put in suprapubic catheters. There are male and female urinals, and I specifically wanted to call out the PureWick system. It's like a vacuum, and it works very well, particularly for women for whom using a urinal is often not really possible. So I can encourage you to check that out. Depression is not that common in ALS, but it does happen. And when someone's feeling depressed, it's important to exclude another cause, like poor nutrition, excluding a respiratory problem, making sure the patient's getting good sleep. And then considering referral to a counselor. This disease is a very challenging disease to go through for both the patient and the family. And then if you add in cognitive or behavioral impairment on top of that, it just doubles the challenges. And so many patients and their families will consider seeing a counselor and starting antidepressants as needed. I particularly like the antidepressant Remeron or mirtazapine because it helps with sleep, mood, and appetite. It does all those 3 things at once. So sleep, really most ALS sleep problems are mechanical. Lack of appropriate breathing support at night, difficulty positioning during the night. And if you're not getting sleep, that's another thing that can definitely mimic cognitive or behavioral problems because you're not able to think as clearly. And so we often start with just simple aids like the rapid dissolved melatonin is often very good. It's just at Costco, or other herbal aids. And then if that doesn't work, then consider a sedating antidepressant, like I mentioned, the mirtazapine or Remeron. And then sometimes the benzodiazepines can be good, like Valium, especially if someone also has spasticity, then you can do 2 things at once. Anytime a patient has symptoms that are bothering them, I try to really look at the whole set of symptoms and think about what are the fewest number of medications I can prescribe to help these symptoms, because many medications do multiple things. Constipation is just a big problem with the disease, so increasing fluids can help, fiber, as well as considering stool softeners like Senna. Lactulose is a prescription medication that that works very well to move things through the system. And interestingly, one side effect of TUDCA, which I mentioned earlier, helps to slow down the disease, is actually diarrhea. So sometimes we have many patients who have not needed to typically take medications for constipation if they are on the TUDCA, or if their insurance covers it, on the Relyvrio. As weakness progresses, it's important to really optimize the home and the work environment and anticipate equipment needs. There can be driving assessments for safety, which is helpful if the patient or the family is not really sure if the patient is safe to drive, and particularly if there's cognitive or behavioral issues. Getting that certification from the DMV saying, yes, this person is safe to drive for the next 6 months can be a good protection for you and your loved one if you're in an accident, for example. So the DMV basically will certify, they do a live driving test, and they basically will certify you are or are not safe to drive, and they guarantee that for 6 months, and then you have to do the assessment again. And then exercise is very important, especially for stronger muscles. So here's some do's and don'ts from our physical therapy group at UCSF, and they recommend doing resistance training for minimally weak muscles or ineffective muscles, definitely doing stretching every day, and then thinking about some sort of light aerobic exercise. Take breaks. It can be even helpful to use your breathing machine when doing exercises if you have one, to give yourself extra oxygen. The important thing is not to overwork or become over fatigued so that you feel weaker after exercise. And then for a muscle that's quite weak, where you're having a lot of difficulty, say, lifting that muscle up, then the strengthening would not really help and could hurt because it could make the muscle even weaker. In California, we have this free work assessment through the AT network. I don't know if you have this, but where they'll come in and basically assess your work environment for safety. There can be home assessments with home safety evaluations through a home physical therapist or occupational therapist. They're often specialty contractors for home remodeling if that's needed. And then hospice, often one nice thing about hospice is they will provide free equipment, things like a wheelchair, hospital bed, Hoyer lift. And so that can be very useful if someone's at that stage and has a lot of needs. There have been so many advances in equipment with lighter weight or orthotics, sturdier walkers. I really like the Nitro Drive walker that has nice big wheels so that it's safer, especially outside. Their manual wheelchairs are much more compact and lightweight, and then there are these electric wheelchairs that you can buy that aren't too expensive and are lightweight to be able to fold in the trunk. And then there are many portable ramps, rail systems. There's even specialized beds that can turn people side to side. That's one of the harder things, that is to feel comfortable at night when you can't move around very well. And then we talked about exercise being important. I didn't really say why, and that is because it helps to prolong survival as well as improve quality of life. It can reduce spasticity. Stronger muscles can absolutely get stronger, even if you have ALS, and then it's important for mood as well. Turning to communication, in this picture are all the different ways we can communicate with others, and there are a variety of options ranging from very high tech, mid-tech, to low or no tech. And so for a patient who has some cognitive or behavioral problems, low tech may be more appropriate because it may be more difficult for them to acclimate to the high tech systems. But it's good to have an assessment and see what is the appropriate technology for, depending on the patient's cognitive ability and preference. Sometimes people may be perfectly sharp cognitively, but maybe they've just never really liked using a computer. And so for them, a lower tech system might work better. And then thinking of very end of life issues, we like to talk about it throughout the disease process in those guidelines that are recommended by the American Academy of Neurology. They mention that it's really important, even on the day of diagnosis, to mention that this is a fatal disease so that people can prepare for that and expect that and not be caught off guard later on in the disease process. We encourage people to enroll in hospice as soon as they're eligible because of all the support that hospice will provide, bringing in medications, someone to call 24/7 if you're having symptoms, and there's a lot that they can do to help manage things, even simple infections, so you don't have to go to the emergency room. And then home care is often very helpful to use if patients are not hospice eligible, like home PTOT, safety assessments, things like that. And then we follow our patients until end of life. So even while they're in a hospice, it's still possible to follow in an ALS multidisciplinary clinic. When patients are in hospice, they can see one doctor, and most patients choose to continue to see their ALS doctor while they're in hospice. Well, in the latter part of the talk, I'd like to return to really thinking about this, this overlap between ALS and FTD and everywhere in between. And so I'm going to talk a little bit about research that, that I've done with my group at UCSF, and then talk a little bit about management and implications. So the two different main studies that I did, one was to look at patients who were coming to the memory clinic, patients who had a formal diagnosis of FTD, and looking to see if they had any sign of ALS. And what we found is that 30% of those patients had signs of either definite or possible ALS, with weakness, difficulty breathing, difficulty speaking and swallowing, and having fasciculations as well. And then we turned the question around and we said, let's look at all our ALS patients coming to clinic, and we'll do testing on them and see how many of them have issues with cognitive or behavioral dysfunction. And we found that about half the patients did have some sort of dysfunction. Early on, the terms for this this problem were either to say they had ALS with no cognitive or behavioral problems, ALS with cognitive impairment, ALS with behavioral impairment, or frontotemporal dementia, actually meeting criteria for dementia. Nowadays, I think people refer to more the ALS FTD spectrum disorder, acknowledging that there's a full spectrum and it can be hard to quantitate exactly where people are in the spectrum, and then also acknowledging the fact that some patients could have very mild cognitive impairment and behavioral impairment. So the term that's most used now is ALS FTD spectrum disorder. And so this is what we found in our group. As I mentioned, about half the patients were completely normal. Around 22% met criteria for frontotemporal dementia. We had one patient with Alzheimer's disease. And then we had this group that they weren't completely normal, but they did not meet criteria for FTD. And we found that about 17% of those patients had behavioral abnormalities, 9% had more executive dysfunction. And then we had the one patient with Alzheimer's disease. And then this was some imaging work that we did, and just very grossly, you can see in column A are patients who had ALS and frontotemporal dementia, and then in column B are patients who had ALS and no cognitive or behavioral abnormalities. And you can see that the red represents atrophy and you can see that there's much more atrophy of the brain in patients who had the ALS and the FTD as opposed to the patients who just had the ALS. Interestingly, the pathology is the same. So in other words, when you look at the spinal cord of a patient with ALS, and then you look at a patient with FTD in the frontal and temporal lobes, it looks the same. So there's basically this protein called TDP43, TAR DNA binding protein, which was found to be the most common protein in both diseases. And mutations in this protein could rarely cause both ALS and FTD. But the real breakthrough came in 2011 when a major genetic link was found. So I mentioned that both ALS cases can be familial and FTD can be familial. Well, this gene called C9orf72 was found to be responsible for 20 to 40% of all familial ALS cases and 12% of FTD cases. And even for people who don't have a family history, this gene abnormality was found. And so in other words, if you have this gene abnormality, you would be at risk of potentially developing FTD only, ALS only, or both. And there are studies done, primarily Dr. Benatar in Miami follows cohorts of patients who have a gene abnormality but have not developed disease yet, to try to look to see if there's subtle signs that we can look for when someone's transitioning into developing one of these diseases. So I think as you've been hearing about some of the symptoms that I've been talking about, things like apathy, being withdrawn, you might wonder, well, is that just coping with the disease? Because it's a difficult disease to cope with and challenging. And so I think certainly it can be a coping mechanism to withdraw or to seek control in some area of your life, or to be angry over the frustration of the disease or be in denial of the disease. And patients certainly have language issues because of the dysarthria. But what we're talking about with FTD is kind of a step beyond that. It's not just coping mechanism. It's something where, for example, someone is just always apathetic or always disinhibited, or maybe they were someone who never used to get frustrated or angry about things, and now they're always getting angry or frustrated. And they often have a real lack of insight into their disease. And language difficulty that's a little different than dysarthria, like really not being able to think of the word or saying words that don't make sense. So these are some of the symptoms of FTD, and that while it can sometimes be hard to sort out, usually over time it can be really clear that this is something new and different and a disease and not a coping mechanism. So I mentioned that there's lots of things we need to be careful of to exclude when we're thinking about this disease, things like depression or another underlying psychiatric disorder. Easy laughing and crying, sometimes people can confuse that for cognitive or behavioral impairments. Like, for example, we talked about people with FTD being disinhibited. So someone who bursts out laughing at a funeral, that might be a sign of pseudobulbar affect, inappropriate laughing. But yet their thinking is perfectly fine and they're mortified that they laughed. So that's very different. And so we have to exclude that as a potential mimic. And then being low in oxygen or high in carbon dioxide, things like using that non-invasive respiratory equipment can often fix that symptom. And then thinking about someone's educational level or baseline intellectual functioning. I've had patients who have been born with cerebral palsy, for example, where they have had some intellectual impairment their whole life. And so if someone didn't know that, they might be thinking, well, why is this person having trouble spelling, for example, one sign of FTD. So understanding where people have, what their baseline is, or their baseline psychiatric disorder. Patients who have schizophrenia, if they develop ALS, they may certainly be withdrawn, and it wouldn't really have anything to do with FTD, but that's just more due to their underlying psychiatric problem. And then one challenge is sometimes if patients are having a lot of difficulty speaking or having, say, arm paralysis, that might limit the testing that we do. And I think someone had asked about what types of tests we do. We typically use something called the ALS CBS, which is a short test that can easily be done in clinic and has a behavioral component to it and a cognitive component. And then another popular test is something called the ECAS, which takes about 20 minutes, a little bit longer. But we try to do the ALS CBS on all our patients when possible to try to screen them for cognitive or behavioral impairment. And then when the disease is just very advanced, it can sometimes be hard to do the testing because patients are tired and can be challenged to position everything right to do the testing. So what about this really mild form that I mentioned? Is it clinically significant? And one study that I worked on with Dr. Richard Olney, who established the ALS clinic at UCSF, was to look at survival, because we thought that the survival might be shorter in patients who had ALS FTD compared to ALS. And then we thought that our impression was that maybe compliance with treatment recommendations was less. And so what we did is really looked at not just ALS FTD, patients with ALS FTD, but more patients with the milder form, just a mild cognitive difficulty, mild behavior impairment. And there was a significant survival difference of more than a year between patients who had some sort of cognitive or behavioral impairment versus ALS alone. And then many authors have found the same thing. There's a shortened survival in ALS patients with comorbid disease, even for moderately impaired patients. And this just shows the actual data that patients who had ALS FTD complied with the NIV, the non-invasive breathing equipment, only 25% of the time, and applied with the recommendation to get a feeding tube only 28% of the time, as compared to ALS patients who were cognitively normal. They had a much better compliance. And this just is summarized here, that patients with cognitive behavioral impairments do have a reduced survival rate. They do have difficulty complying with things like PEG and BiPAP and may require extra education and patience to adapt to this equipment. It can be an important cause. It's important to recognize that it can be very distressing for the caregiver. A caregiver may have a spouse, for example, who their whole life was very clear in their communication, very loving, and suddenly that person's becoming distant and they don't think that they have the disease. And again, some of this can be due to coping, but this is one step beyond coping. This is an actual, it's a brain disorder, and the patient really can't help what they're doing, and but it can be challenging not to take it personally if someone's having some major personality changes. And then there can be poor safety awareness. Patients can fall, patients can choke because they're taking too big of bites of food. And so it's really important to be aware of that and try to just basically have more monitoring. So typically for a patient who's cognitively normal, they may be very careful in the way they get out of bed and always using the walker, say, when they're going to the bathroom. But if the patient has some behavioral impairment, they may be impulsive and they may think, oh, I don't want to wait to get the walker out. I'm just going to go to the bathroom. And so falling is more common, and then not taking care to take a small bite of food can also cause problems as well. It can be very challenging to manage important decisions. If you think about a patient who, say, is in denial that they have ALS, and maybe the family is saying, well, we need to make sure that we get a will together and that we know your wishes and get an advance directive together, and the patient may not think that's important, because if from their perspective, if they don't think they have a disease, then they're not going to do that. Or patients may stay at work longer than perhaps they should, and they may be fired because they're not performing well on the job. And so there's many important decisions that someone with ALS needs to make as far as their wishes in the future, as far as how long they want to work, things like that. And if the patient's having some cognitive or behavior changes, they might not be able to do that. There can be a lot of implications for stem cell therapy. Stem cell therapy is not ready yet. The Brainstorm trial, unfortunately, was overall negative. That was the major stem cell trial that we had, although it looked potentially promising for a smaller subset of patients. But these stem cells are going in the spinal cord, and so if we have a problem in the frontal and temporal lobes, how is the therapy going to be able to get there to be able to help in that way? So I think it's important as we think through our therapies for ALS to think through how can we treat both the spinal cord issues and the brain. And then it very much impacts communication options for patients. Some of my patients who have cognitive and behavioral problems have a really hard time learning using the eye gaze system, for example. It takes a lot of patience and effort to learn how to use some of these more complicated communication systems. So sometimes patients end up needing to stick to simpler systems as a result. All right, and so in summary, we have medications available to treat many of the symptoms of ALS. We can slow it down, we can treat a lot of the symptoms that are bothersome, and we just don't have treatments yet to actually reverse weakness or actually treat the behavioral or cognitive impairments. And then equipment advances help people be more independent than ever. One equipment advance I don't think I mentioned that's kind of interesting is a robotic arm. I have a patient who's paralyzed in a wheelchair on a ventilator, but she has a robotic arm that she's able to manage and feed her dog and open doors and things like that. So there's always ever more advances in equipment that are helpful. And then multidisciplinary clinics, as I mentioned, are really the thing we have that improves both quality and quantity of life more than any other treatment that we have to date. And then lastly, it's just really important to be aware of the cognitive and behavioral impairments that impact survival and management, mostly for family education and trying to think about how to help patients stay safe. And then I've been talking about the multidisciplinary ALS team, but if you haven't been to an ALS clinic, you might not be aware of all the different people involved on a team, but typically there's a neurologist, a nurse, a speech pathologist, a dietitian, a respiratory therapist, a physical therapist, an occupational therapist, a social worker, a rehab technologist. Sometimes the speech pathologist also is the person that does communication, and then a psychologist. And then there are often consultants like a rehab physician, a pulmonologist, a GI doctor, and then there can be many associates like research scientists, representatives from the ALS Association and Muscular Dystrophy Association. And then I just want to acknowledge my team. This is us doing the Ice Bucket Challenge, whenever that was, I think 2015 or something. And I've been with this team for a very long time, and I'm very grateful for all of their support. So I think I'll stop now and answer whatever questions you have. Thank you.
Thank you so much, Dr. Lomen-Hoerth. So let's get into some of the questions from today. One person asked, how can allied professionals help in the caring for people with cognitive issues?
I think that's a great question, and I didn't, and there's a whole list of strategies on the ALS Association website, but I think some of the basic ones are, first of all, try to be very slow and clear with your communication. Try to respect that the patient may not have an awareness of their needs or a willingness to accept equipment, so trying to help involve the whole family to kind of rally around and help, and then ultimately accepting if the patient is choosing to reject certain recommendations. I think I've heard some people say that one should phrase things in the way that you might a child, like, okay, it's your choice. You can use the walker and not fall, or you can choose not to use the walker and fall, and trying to just phrase things in a choice format so that people understand, if you do X, this will happen. If you do Y, this will happen. And again, accepting that choice in the end, and then just doing what you can to try to keep people safe.
Yeah. Another person asked, as I'm scrolling through here, you talked about some different studies that looked at FTD. Do you know of any studies that have combined ALS, FTD, and another disorder like bipolar?
In the FTD literature, there's a lot of research about the prodrome. So the idea that patients may have some sort of psychiatric disorder, like say bipolar disorder, and then over time they transition into FTD. That's not to say that everyone with bipolar is going to be at risk of getting FTD, but there are definitely some, say you know you have a family history of ALS or FTD. These would be some signs you might look for early on.
Yeah.
But it's a great question because some of the symptoms can be very similar, and I think that the difference is the progression, and also there are certain tests of executive functioning that would help distinguish between someone who has ALS and bipolar disorder and then ALS and dementia. And certainly a lot of the psychiatric disorders, besides depression, often can start very early in life, like schizophrenia.
Do you know, are there risk for environmental risk factors the same or different with genetic ALS?
We assume they would be the same. So in other words, whatever would cause someone to be at risk for developing ALS, we would think that that people with familial ALS would not be immune to that, but maybe it would impact whether perhaps when the disease starts. I think that's one of the big mysteries, is you can have a particular gene defect in a family, and in one family member it might start at 35 and another family at 72. Why? You know, is there something different about, is it genetics? Is there something different about the genetic makeup that they have, or is it related to the environment? And is there something about the environment that the 35-year-old was living in compared to the 72-year-old that made them be at more risk for getting the disease earlier? These are great questions that we just don't know the answers to yet.
Yeah. Do cognitive and behavioral impairments always show up on an MRI with atrophy of the frontal lobe?
That's another really great question. And interestingly, we've had patients with ALS FTD who will have just a completely normal brain MRI. But then when they pass away from the disease, we can see pathological changes. So it takes time. I think the first step is for a cell to die in a particular region, and then atrophy follows. And so sometimes if something is happening very acutely, then you may completely miss it on the MRI. There's a lot of investigation doing research into other types of imaging to try to help identify things earlier, but it often is invisible.
Yeah, yeah, that's a really, really great point. Another question is about FTD, and does it affect emotions, specifically like emotions of like love or affection? This person says that it was really hard not to hear kind of those words of affirmation, yet kind of seeing a spark in the person's eyes.
Yeah, it's a great question, and it's just really so heartbreaking because people often have this history of having this very loving relationship, and then things change and suddenly the person is just not initiating, not really being very apathetic, and not expressing those kinds of emotions the way they used to. And I think the one thing I usually try to reassure people is that this is not something they're consciously doing. They're not consciously feeling like, oh yeah, I just don't feel loving towards you anymore. And I'm not saying that. It has nothing to do with that. It has to do with changes in the brain that are causing them to behave in this way. And but they're, it's nothing about what the person has or hasn't done. They're not doing it consciously or willfully.
Yes, yeah. And then in addition to cognitive challenges when using a speech generating device, have you witnessed an apparent relationship between like a med regimen and eye gaze ability?
Oh, absolutely. So if patients are really anything that affects cognition, so whether it's that they're not using their breathing machine and they have CO2 retention that's making them sleepy, or they're taking Valium or baclofen for their spasticity and that's affecting their cognition. Typically it would be sleepiness that the medications would cause, making it difficult to use the eye gaze system, but sometimes people can be awake and feel confused because of the particular medications that they're taking. So that's why we just have to be so careful when someone's having problems with a task, really dissecting out, is it a motor problem? Is it a cognitive problem? If it is a cognitive problem, what are all the causes, and trying to systematically try to fix those.
Yeah, just even as you were talking about just if somebody could benefit from non-invasive ventilation, like, oh yeah, no, that definitely, it helps with alertness, it helps with executive functions, it helps with learning a new skill. So that was something, going back to my practice as a speech pathologist, like, oh, right. Yeah, there's all these other little things that could be impacting somebody's cognition.
Exactly. And I want to add one more thing. I think it's very important not to make assumptions about what someone can and can't do. So my most severe ALS FTD patient that I ever had could not speak, was in a nursing home, hardly could move. He absolutely loved his feeding tube and his NIV. And he was sometimes patients with ALS FTD can be very meticulous and focused. And so he had like a calendar that he wrote, exactly when he gave the feeding, and the same for using the machine. And so I think it's important not to assume that people are too impaired and wouldn't benefit from a treatment. You can be surprised.
Oh, thank you so much for clarifying that. And I think that answers a question that had popped up. This is going back to the slide about TUDCA. If a patient is waiting to be approved for Relivrio, would you recommend starting to take that supplement?
Absolutely. So absolutely. I think the moment you have an ALS diagnosis, while you're waiting to see if insurance pays for Relivrio, I would start TUDCA. The one qualifier is that if you do not get approved for Relivrio and you want to be in a clinical trial, TUDCA is still one of those excluded supplements from clinical trials. So
Okay.
It's kind of weird. It's like, yes, Relyvrio is allowed because FDA approved, but the TUDCA part is not. So I would just make sure to check if you are interested in clinical trial, if TUDCA is or is not allowed, because you have to have a washout period of 30 days. And so you may not want to waste that time. So that would be the only caveat.
Okay. And then somebody had mentioned a neurologist had diagnosed their loved one with frontal temporal cognitive disorder. Does that fall along that spectrum you were talking about?
Exactly. Yeah. Yeah. I think it got to be kind of cumbersome to say ALS-CI, ALS-BI, and what does this really mean? And then, ALS-BI and ALS-CI. So I think that's why at the last ALS frontotemporal dementia consensus meeting, they decided to change the term to just ALS-FTD spectrum disorder.
Fantastic. And I think that is all of the questions. If I haven't gotten to your question specifically, I will email you a direct answer. So if some questions were maybe we just couldn't get to today, because I do want to be mindful we are at time, I will get you an answer. I can email that to you directly. Also, a reminder that this will be recorded and it'll be up on our website. And I want to plug our next ALS Learning Series, which is long awaited. Thank you everyone who had signed up for our December Learning Series. We did have to postpone it, so Hannah Reed, PT from Shirley Ryan Ability Lab in Chicago, will be talking about ALS and exercise. And thank you, Dr. Lomen-Hoerth, for those wonderful slides. Those are a great primer to what Hannah will be talking about in April.
Thank you so much. I really appreciate being here today.
Oh, of course. Thank you so much for your time. We really appreciate it. And thank all of you who are on this webinar, who gave up, if you're in the Central Time Zone, your lunch hour. I really, really appreciate it. You will see upon ending of the webinar, there will be a survey. Please fill that out. It just keeps us up to date on what you guys are all looking for, and it makes us provide better materials for everyone. We also want to interact with you on social media, so please find us at Les Turner ALS Foundation on Facebook, Twitter, Instagram, LinkedIn, and YouTube. Thank you all. I hope you all have a wonderful rest of your day wherever you are. Please stay safe and healthy, and we will see you in April. Thank you so much, everyone.
Thank you. Bye-bye.
Bye.